appreciate the opportunity to talk to everybody on a subject that can be sometimes anxiety provoking. No one, I think, is eager to have surgery, especially when it's associated with the C word. And so skin cancer can be kind of debunked as far as what folks may anticipate for their treatment, specifically surgery. So in broad strokes, there are really two main approaches to treat skin cancer surgically. And one is by standard excision, sometimes referred to as wide local excision. We'll talk a little bit about why it's called wide local excision. And then the other type of treatment surgically is Mohs micrographic surgery. And no, it is not mole surgery. Mohs is spelled M-O-H-S, and it refers to the surgeon who invented the technique, Dr. Frederick E. Mohs, who essentially started doing resections of affected skin as a general surgeon and found a way to look at all of the cells at the edges of the resected skin. So let's start just historically with traditional surgical excision. We know that, at least in dermatology, one of the great things about being able to treat skin cancer is that it's readily accessible. It's on the skin, we can see it oftentimes, and there are clear signs and symptoms that something is not normal. And so we can use those as clues to discern what we need to remove on the skin, but our eyes are limited. And we know that because if we were to remove only what we saw on the surface of the skin, and that was representative of everything underneath the skin, we would have a perfect cure rate 100% of the time. And that's not the case, unfortunately. So with wide local excision, it's termed wide because we have to account for an additional, what we call margin or amount of skin around what we think may be the skin cancer. And I take that into account. It's almost our way of implementing a fudge factor, if you will. So for very common skin cancers, by far and away, number one and number two, basal cell carcinoma and squamous cell carcinoma are the most common subtypes or types of skin cancer. And we have established very well-established guidelines on how much skin around the perceived tumor to take. And so somewhere that range is anywhere from 4 to 6 millimeters. And if you were really to take the opportunity to measure that out for yourself, when you're going around the entire perimeter of what is seen as skin cancer, that's quite a bit of extra surgery in order to have the confidence that you got something completely. So Mohs micrographic surgery changed our way of managing skin cancer in a way that allows us to do two things. One, it allows us to make sure that we can see what we can't see. And what do we mean by that? Well, when you have something sampled or biopsied, in order to assess whether or not you have a skin cancer, that's sent off to a lab. They section it into what we call breadloaf sectioning. So you have a piece of tissue and you're just taking two-dimensional representations of a three-dimensional structure, and hopefully you have an adequate sample to give you a diagnosis. Well, the way we do that in Mohs surgery is different. Instead of imagining a bread loaf, we're taking that piece of skin that's removed, and if you imagine a piece of pie, the innards, the inner contents within the crust is what we're concerned with. We want to get all that skin cancer out, and then we want to look at the margin or the side perimeter and the deep part of that tissue and make sure that there's no tumor extensions beneath what the eye can see. So Mohs surgery is great because after we take that skin out, we can take it to our lab real time. We don't have to send it out. We can use our lab within our office in an ambulatory setting, outpatient, and we're able to freeze that tissue down, put those sections, two-dimensional sections that allow a 100% evaluation of that three-dimensional structure, and stain it and look at it under a microscope to make sure that there's no extensions beneath what the eye can see. If there are extensions, we know about it. The microscope tells us right then and there, and we go back and we only take what is necessary from the remaining defect. And how do we know where to go? Well, we real time make a map to make sure that there's we know precisely where that root of cancer is. So that's, in a nutshell, kind of the procedure. The technique is really making sure that we're able to precisely map out the trajectory of the cancer. Another analogy is really what you can see is the tree root and all of the tree trunk and all the roots that we see or that we don't see lurking beneath. We trust the microscope to tell us that information and make sure that everything is removed. So number one, by looking at 100% of the cells under the microscope, we're able to have, in many cases, particularly for non-melanoma skin cancer, basal cell carcinoma, and squamous cell carcinoma, we can achieve up to 99% cure rates within a 5-year period. So that's been a tremendous, advancement in modern medicine, because with standard excision, we see some of the 5-year cure rates being anywhere from 89% to about 92%. So, if you, roughly speaking, 1 out of 10 of every patient recurs with their skin cancer, that's really not something that is ideal in our setting, particularly for how accessible the skin is and how otherwise easy it should be to treat. The second major component about Mohs surgery, as far as a benefit relative to other treatments, particularly traditional surgical excision, is that it doesn't carry wide excision in its name. It actually really focuses on tissue conservation. So we start only by taking what we see and trusting the microscope thereafter. And this is really important for areas of the body affected that have either a functional or cosmetic importance. So Mohs surgery, is it necessary everywhere for every tumor? Certainly not. And we do have guiding criteria and principles to help us make informed decisions about who we treat with Mohs surgery. But the main goals are tissue conservation and exceptional cure rates. So about Mohs surgery in terms of, and I see there's a question that came up that I'd like to address at this time, which is, what is immunohistochemical staining and how does that factor in and why is it important during Mohs surgery? This is yet another advancement that we've had even in the last decade that's really changed the way we treat even high-risk tumors. So even things beyond basal cell carcinoma and squamous cell carcinoma can be treated effectively with Mohs surgery, and the literature is now starting to reflect that. And that's been especially important with melanoma, particularly melanoma in situ, which is a type of cancer of the pigment cells called melanocytes of our skin. And it gets bad press because many people who are probably on this call understand that melanoma can be a bad actor and spread through the body. So local control is really of utmost importance when we're dealing with early disease, especially. And immunohistochemical staining is another type of technique that we can use real time that allows us to increase the contrast between those pigment cells and other normal skin cells. So that has really changed the game in terms of how we've been able to have better cure rates for cancers like melanoma beyond basal cell and squamous cell carcinoma. Right now, the latest evidence is that there's about between 8 and 10% of Mohs surgeons who are fellowship trained across the country who are actively practicing with the use of immunohistochemical staining for certain high-risk tumors, whether it be melanoma or a advanced stage squamous cell carcinoma, or even other more rare orphan diseases like extramammary Paget's disease. But this is starting to be more regularly implemented into our fellowship training. And fellowship training is something that I would really encourage all patients to seek out in their Mohs surgeon, because it is a rigorous process by which the surgeon is trained over a course of 1 to 2 years, where the minimum requirement in that time period is to have at least 600 Mohs surgeries completed before your level of proficiency can be adequately evaluated. And it's not just the surgical resection. I think a lot of people get caught up in the removal of the cancer and the actual reconstruction of the wound that we create in the process. And we'll talk about reconstructive surgery. But really the pivotal point that makes Mohs surgery different than traditional surgery is the ability for the surgeon to also act as the pathologist and to make sure that to their trained eye, they can see that there's no evidence of skin cancer left behind. So I would argue that is the most important part, because what's the point if we can't tell, even with the use of the microscope, that the cancer is completely inadequately removed? Then we have a false sense of security that we're effectively treating. So what to expect from Mohs surgery, or any surgery for that matter? For Mohs surgery and traditional wide local excision, at least in the dermatology office, this setting is an outpatient-based procedure where folks are awake. They can communicate. Oftentimes during surgery, at least the reconstruction part, there can be music, and we kind of tailor the day to the patient's comfort level. But really, in terms of steps, it starts with informed consent. And my mentor, Dr. Dave Broadland, said it best: the informed patient with informed consent can make an informed decision. So whenever you're talking with your surgeon about what to expect and what are the alternatives to surgery, because there are alternatives and they have their own pros and cons with regard to cure rates and side effects and expectations for healing, it really starts with a complete understanding. And for people who want a little bit better illustration of the process, I welcome you to go to the mohscollege.org, where there is a patient portal that you can see a really nicely done video on the technique. And that's something I think really is helpful for patients who might be anticipating surgery. Local anesthesia is the hallmark of how we keep people comfortable. So the other benefit of doing these types of outpatient procedures is that we're not subjecting folks to general anesthesia. So usually this is done with mixing lidocaine 1% with some epinephrine, which allows us to limit bleeding at the site of surgery. It kind of shuts down the highways that bring blood to the sites, that we don't have a field that is obscured by bleeding. And I think it's a little less, kind of disconcerting for patients and when we use it. And we also add sodium bicarbonate, which allows us to buffer our anesthesia to make the actual act of injection a little bit more comfortable. A lot of people with local anesthesia without buffering often find that it stings quite a bit, and that reflects the lower pH or the acidity of the solution. So most surgeons and dermatologic surgeons and plastic surgeons, if they're getting involved in reconstructive surgery after Mohs surgery, use this technique. And then finally, sometimes there can be mixed in with your solution a antibiotic, most often clindamycin, that really has helped reduce a lot of the post-operative infections that we see after Mohs surgery. But that being said, the risks of Mohs surgery or any skin surgery are quite low, less than about 1.5%, regardless of anatomic location, age, or other factors, yield an infection after surgery. And this is really mitigated by, really impeccable technique, making sure that the field is clean, sterilized. We use sterilized instruments. We also use sterile technique, at least with the reconstruction part, clean technique for Mohs resection part. And then also, once you're comfortable and you're numb, we do the Mohs resection part. And that's where a lot of the counseling about the day centers around the wait time, which is kind of, it's funny because we've really made tremendous advancements to be able to take our specimens, which we usually send out to outside labs for a biopsy. If anyone has had biopsies done, you'll know that it takes about 1 to 2 weeks to get some of those results back. And here we are, have condensed a lot of this processing real time into a period of about anywhere 60 to 90 minutes. And it's a little bit longer for the immunohistochemical staining that I mentioned earlier. But bottom line is, it's been really a revolutionary technique to be able to condense that information down into one day. And we usually counsel our Mohs patients to be prepared to spend the day, albeit we really don't find that that's necessary for most patients, because take, for instance, basal cell carcinoma. We may have one attempt and get it clear, and then focus on what we're going to do about the wound and proceed to a repair or reconstruction or some other form of wound healing. Or it may take multiple attempts of Mohs surgery. We mentioned the precise mapping. So if we do have roots, we have to go back until it's clear. With basal cell carcinoma, the national average is about 1.6, 1.7 attempts. So somewhere between 1 and 2 attempts in general is what's necessary to remove a basal cell carcinoma. And that follows suit for most non-melanoma or small skin cancers. But the day can be unpredictable. And I think, if you become prepared, that it's a lot more enjoyable and less uncertain. As far as once we get the cancer clear and we have a wound, we enter into a phase of reconstructive surgery. And I have a lot of people ask me questions. Well, is it done the same day? Do I need to go to a different surgeon or a plastic surgeon? And the answer is, with fellowship training evolving with this rapidly evolving technique, most fellowship trained Mohs surgeons do the reconstruction immediately after Mohs surgery on the same day. And that there's benefits to that, because any open wound that has a delayed reconstruction can sometimes be subject to a longer period where it's left inflamed, open to the elements, so leading to a little bit higher infection rates, or other unforeseen circumstances where it's better to do same-day reconstruction. So what is reconstructive surgery? It sounds kind of scary. All it is really addressing the wound that we've created with Mohs surgery. And it shouldn't be scary, because with Mohs surgery, again, one of the primary goals is tissue conservation. So we expect that the wounds should be as small as they possibly can be in order to effectively treat the cancer. One miscommunication or misunderstanding, I think, about plastic surgery and that terminology is that skin has really many different properties, but the elasticity and the plasticity of skin are kind of the yin and yang to each other. So elasticity is the property of skin to be able to stretch or snap back to its original position. So if you pull on your arm skin and it snaps back as it normally should, however long it takes, that's the elasticity of the skin, the ability to hold and retain its original shape. Plastic surgery should not be confused with cosmetic surgery, because this is certainly not cosmetic. Plastic surgery can be used in post-Mohs surgeries. And so plastic refers to the other property of skin, which is that the human body has an incredible ability to take new shape and stay in that new shape adequately. So you can see how the elasticity and the plasticity play a role in describing that discipline of plastic surgery. It's really just about making sure that we're able to repair wounds that we create at the time of Mohs. Now, we do that with different techniques. In some cases, no stitching is required. If we're able to keep the wounds as thin and as narrow as possible, a technique called second intention, where we're invoking Mother Nature and Father Time to essentially help us out with a little bit of tender love and care, is a perfectly fine approach. And it's really one that is more appropriate in some anatomic areas of the body than others. Specifically speaking, those that are kind of cup-shaped, we call concave. Areas that would include kind of the concavity or that cup shape would be on the temples, kind of in the root of the nose where it meets kind of the corner of the eye, and other places that your surgeon can help you define as appropriate for allowing to heal on its own without any stitch work. But other types of reconstructions involve simple linear closures, like side to side, where we're just simply moving two tectonic plates of skin, if you will, to make sure that they cover that wound. And then there are other types of techniques called flaps and grafts. And so this is really an element where most surgeons excel, because their training is uniquely aligned with being able to address very small, what we call micrographic, hence the name Mohs micrographic surgery types of closures. Grafts are really nice because they're a technique that allows us to accelerate what Mother Nature and Father Time would already do on its own without doing anything. But sometimes wounds are too deep or too broad to really realistically heal on their own. And so grafting is nice because it really doesn't create more of a wound where the Mohs surgery was done, but it allows us to harvest some extra skin in places where we do have extra skin, whether it be on the neck or in the back of the arm or on the thigh. And it allows us to plug that little hole like, kind of a piece of sod, and allow that time frame for healing to diminish. Now, flaps, on the other hand, are a little bit more of a predictable type of outcome. And what I mean by that is sometimes when you have a piece of skin that's just plugged in, like we just talked about with the graft, the color and the texture and some of the properties of that skin are different than the recipient skin. And so sometimes it does look like, Patch Adams, where there's a little bit of a discrepancy there. So grafts are nice because they're really utilizing generally adjacent skin to the actual wound itself and allowing us to move things, rotate or advance adjacent skin into that wound without having to completely remove it from the patient. So what that enables us to do is keep a blood supply intact so that the color matching, the texture, and ultimately the scarring is optimal. And that's a really fine approach as well. How we decide between these options really depends on the extent of the surgery, patient preferences, their understanding of what's involved with wound care, and also certainly guided by your Mohs surgeon. Okay, as far as safety, we get this question a lot, and I think we can all appreciate that skin is very different than something more invasive like colon surgery or even an appendectomy where our appendix is inflamed and we have to have that removed because skin is very readily accessible. But it's not without risk. We talked about a little bit about bleeding, infection, and other types of complications. But at what age or at what point is it not worth treating the skin cancer? And that's, I think, a very difficult question to answer. And until recently, we didn't really have any evidence to support or refute Mohs surgery in people who were at the polls of their age. For instance, the elderly, age 75 and above, for instance, until we had a very good study done in the last few years that was looking at the functional status of individuals above the age of 75 and trying to discern, well, how well tolerated is Mohs surgery? And the answer is, by and far, the majority of people who present for Mohs, if they're paying attention to their skin, assuming they have good screening with their dermatologist or the general practitioner, most skin cancers that we see tend to be in early stages and small. And so the morbidity associated or the risk associated with doing the procedure is very low and well tolerated. And this study that was done supports that. And it specifically used something called the Karnofsky score that evaluates functional status. And so there's really no age that we say is inappropriate. If we had a crystal ball and someone said, at least for basal cell carcinoma, that, doc, I might die within 6 months, then certainly that's a conversation where the utility and the benefit of undergoing something like that is really up to the patient and their family. But as far as someone who is in their 90s or even, I've had patients in 100 years old who are really, bothered by this bleeding, ulcerated, painful lesion on their skin, and who have ultimately opted to go undergo the surgery and have tolerated it quite well. So we're really mostly concerned with functional status. If you're someone that can ambulate or move or walk or assisted or unassisted, doesn't matter, as long as someone can understand what they're up against, and you have a Mohs surgeon that's really providing good informed consent. That is the primary, consideration for proceeding with surgery. What are some of the expectations for returning to a normal lifestyle, getting back to work? And what are some of the expectations about scarring? So anytime we do surgery, we expect scarring, and there's really no way around that, but there are ways that we can help a scar along and mature as best as it possibly can. As far as going back to work or getting back to a lifestyle, your normal lifestyle, whether it be working out or taking hikes or, just doing odds and ends around the house, that really requires an understanding of normal scar maturation. So I like to tell folks and give them a little bit of anticipatory guidance about their scar timeline. So immediately after surgery, whether you're using dissolving sutures or stitches or non-dissolving, there's always going to be a degree of inflammation that usually maximizes at around 2 weeks. So what is inflammation? How do you define it? Well, redness, swelling, some discomfort, and some warmth to the skin. Those are kind of the hallmark features of inflammation, and we expect that. Around up to 6 weeks from the time of your surgery, a lot of people will characterize daily change, where they're seeing something different than they saw the day before. And that's also very normal. That really reflects all of the remodeling of the scar tissue that's happening both on the surface and also beneath the surface within the scar. Between 6 weeks and 3 months, that kind of daily change shifts, and it really slows down quite a bit. You might see weekly to biweekly change. And then certainly between 3 months and 6 months, there's really nominal change. By 6 months, most people can't really tell from 6 months to a year out, looking at the incision, that there's any appreciable difference. That being said, scars are constantly undergoing change all the way up to 12 to 16 months. And so being cognizant of that fact and also being patient with your recovery process is just as important to manage folks' expectations and what's considered normal. Also going back to your activity and your lifestyle really depends on the anatomic location. Without getting too much into the weeds, I'll defer that to the discussions between individual patients and the Mohs surgeon or the skin surgeon, because those are really unique circumstances, and I think everybody has a slightly different take on. How to speed healing, and I see some questions on here with regard to natural remedies or other types of things like what can I put on my scar to improve it. By far and away, the most important thing to remember is we need scars to stay adequately hydrated so that they can help new skin in the proliferative phase. So there's 3 phases of healing. So there's inflammation we talked about that really happens starting within the first day. Within the first couple of weeks, the proliferative phase refers to the ability of new skin to start leapfrogging over the wound that was created, whether it's stitched or an open wound. And that's a really key part. So if a wound is adequately hydrated, the skin cells have less resistance to be able to leapfrog over themselves and cover that wound. If it's the old adage that to let a wound breathe and air out, if a wound is not adequately hydrated and too dry, what ends up happening is the natural progression is forming a scab. We call that a hemorrhagic crust because there's bleeding and growth factors that go into forming that scab. And each time the scab is either artificially removed, picked off, or sloughed off, it leaves kind of a crater or an etched line if your wound has been stitched. And so it's super critical to be able to keep a wound adequately hydrated. And the best way and the easiest way that I recommend doing that is with regular petrolatum or petroleum jelly or Vaseline. Another component of that or option is Aquaphor. These are all very commonly attainable items that are in the pharmacies. And what's nice about it is it not only hydrates, but as a thick ointment vehicle, it allows some degree of protection from the environmental elements around you, whether it be dust, debris, or microorganisms. So that's really, really critical. And for how long is it critical? Well, until all the raw areas of the wound are completely healed. So that we want, whether it be the new skin or scar, to be an even kind of smooth texture whenever you're running your finger over it. If there's any weeping, if it appears raw or wet, you're not done. And I would encourage you to continue applying that Vaseline. Natural remedies, this is a really, I would call it an opportunity to learn, because I think most surgeons or physicians in general, this is not a field in which we've allocated a lot of time, energy, and resources to investigate. We're really at the mercy of the evidence available to us, not to say that natural remedies cannot help. Some commercialized natural remedies, just to throw a couple names out that are common that I hear in clinic, but I have no conflict of interest, would be something like Mederma, which is an allantoin compound, which is a plant extract. Sometimes people talk about, ingesting things like arnica, which is also a byproduct of a plant. These are things that don't have a lot of evidence behind them, albeit there have been reports of anecdotal benefit, but they can also sometimes induce extra inflammation and irritation because the dosing and the application itself is not widely studied prospectively, meaning from start to finish. And there's really only evidence insofar as patients individually report benefit, and we have no way of tracking whether or not there's significance to it. Doesn't mean there may not be a benefit. It just means that we don't know how to counsel folks. And I would argue that really the only alternative to the use of Vaseline to keep the scar hydrated is if someone is particularly, whether in their history or their family has a known history of what we call hypertrophic or bulky scars, or even keloids. Keloids are basically hypertrophic or bulky scars that grow beyond the initial scar itself. So not only do they grow in height, but they grow in width. Silicone has actually been shown to have mixed evidence, but I'd venture to say that there's more evidence than other homeopathic or naturopathic remedies, because it actually allows us to diminish some of those overproduced growth factors that don't know how to turn off when they should turn off. And so whether it be silicone-based gels or silicone sheets applied over the wounds, they sometimes can mitigate the risk of a bulky scar or a scar with a texture that's not like normal skin. But I would defer those discussions again to the one-on-one that you have at the time of your informed consent with your surgeon. So we talked about Mohs surgery versus wide local excision. We talked about what to expect, some of the reconstructive surgery principles and expectations after surgery. I want to go to some of the extra questions that we've been seeing in the chat box. And I'll start with, will I need general anesthesia? We talked about that. Really, the need for general anesthesia doesn't come unless you have a unique collaboration where, for instance, if a patient with a rare tumor, I mentioned extramammary Paget's disease, it has a colorectal surgeon that would like clear margins so that they know anywhere within those clear margins around the tumor, they can resect the tumor adequately. That's really, a case wherein general anesthesia sometimes is used not by the Mohs surgeon or the dermatologic surgeon, but by the surgeon that they're collaborating with. So it's a very rare case, but by and large, most of our surgeries are done under local anesthesia. Will I be in a lot of pain after surgery, and how is the pain managed? That's a really, really good question. And there's been, it's actually surprising that not a lot of people complain of significant pain after the first 24 hours from surgery. Usually anesthesia, local anesthesia, with lidocaine wears off somewhere between 4 to 6 hours, assuming that we've combined it with that epinephrine we mentioned. At that time, around 8 hours after surgery, the last time you've been treated with local anesthesia, one can expect peak pain. Now, peak pain is different for everybody, but it certainly is not any individual's threshold for maximum pain. Usually we get out of 6 out of 10 or 7 out of 10 in the worst cases. Most people are pleasantly surprised that, with appropriate dressing and pressure bandaging, that the evening of their surgery, they're in pretty good shape. But when we manage pain, we also think about, okay, well, we don't want someone to suffer. So what can we give someone in order to be comfortable? And there have been quite a number of studies now that have looked at skin surgery specifically, and Tylenol, ibuprofen, and Tylenol number 3, which is essentially Tylenol or acetaminophen, 300 milligrams combined with 30 milligrams of codeine. So that Tylenol number 3 is a controlled substance. It is in the opioid family of medications. But only 95% of the time do we, really lean on, or 5% of the time, I should say, 95% of the time, we don't lean on opioid medications. So it's a very rare circumstance that we do. And even when we compare head to head with acetaminophen, which is Tylenol, or ibuprofen, or other types of NSAID family medications like Aleve, we find that the combination every 2 hours of 1,000 milligrams of Tylenol and 400 milligrams of ibuprofen, alternated every 2 hours, is superior not only in managing immediate postoperative pain, but the durability of effect is also superior compared to Tylenol number 3, which is an opioid. And so that's great because there's, it's over-the-counter medication. It's readily accessible. It doesn't require a prescription, keeps people comfortable, and it also has less side effects related to the opioid family of medications and the addictive behavior that family has been associated with. As far as the role of radiation therapy, this is not a common question up front from the patient side. This is really something that's driven by the surgeon. I will say that there are some tumors or specific cancers that are particularly radiosensitive, and some that are not. For instance, we know melanoma is not a particularly radiosensitive cancer, and therefore it is really not the mainstay of treatment for early or intermediate stage disease. For all types of skin cancers, the most important concept to really nail down is local control. So attacking it early, and when it's attacked early, removing it completely. There are roles for radiation therapy with certain high-risk features in specific tumors. And without getting into too much extraneous detail, the second most common skin cancer, squamous cell carcinoma, has been shown to have a role for what we call adjuvant radiation therapy whenever there are high-risk features involved. And how you define those high-risk features are really innately related to the tumor itself. So when a Mohs surgeon or a skin cancer surgeon gets the pathology reports from the biopsy back, if there are features that really indicate that this is a bad actor, sometimes in select circumstances, a discussion about radiation therapy is warranted with the patient. Another skin cancer that we see that is particularly radiosensitive is Merkel cell carcinoma. We found in a study that was done even within the last 2 years that wide local excision and plus radiation therapy, particularly for the head and neck with Merkel cell carcinoma, is considered standard of care. When we treat with Mohs surgery outcomes alone are comparable or at least as effective to the combination of wide local excision and radiation therapy. And that's been a relatively new, hot off the press type item. We're still, I think one should realize that we're still evolving these practice guidelines. And so it's much more nuanced than what we can say in broad strokes on a forum like this. So I think it's a fantastic question, but I hope that no one needs it. But I think that your surgeon will be well equipped to initiate that conversation with you. Okay, I have some more questions rolling in. We talked a little bit about Mohs for melanoma. I want to just flesh that out a little bit because melanoma is a cancer that has a inherently different biologic behavior compared to non-melanoma skin cancer. Mohs for melanoma, so when you think about melanoma and its growth pattern, we mentioned earlier for basal cell and squamous cell, the tree trunk analogy with the roots. Unfortunately, melanoma does not behave like that. It's not what we call a contiguous tumor. So we cannot as easily follow out from the center or the bulk of the tumor to the definitive end of the tumor. Why? Because melanoma actually acts more like a mothership, and it sends out these little satellites that can spread either locally in the soft tissue, or it can access the lymphatics or the blood vessels. Part of the criticism for Mohs surgery in its use treating melanoma has been that because we cannot follow out that tumor, then how should we expect to have clear margins and have tissue conservation? And that's really the main question. So we talked about Mohs surgery having those two goals: complete cure or better cure rates compared to non-Mohs surgery, and tissue conservation. Well, the priority for tissue conservation and the treatment of melanoma is really not as primary. It becomes a secondary aim. There's been a lot of studies historically looking at general surgery and the adequate margins to treat melanoma, starting with 10 centimeters compared to 5 centimeters, 6 to 3, 4 to 2. And the guidelines currently for an intermediate or thick melanoma treated with wide local excision is anywhere from 1 to 2 centimeters. So Mohs surgery can take those same margins or sometimes slightly less, and we're able to not only have that same amount of tissue resected, but we're able to look at all of the cells under the microscope, plus the use of the immunostaining that we have to highlight specifically the melanocytes that are impacted by this cancer. And so it's another layer of protection, if you will, that has really fleshed out in the evidence to have at least non-inferior cure rates when it comes to treating trunk and extremities, but it has significant help in head and neck, as well as salvage of digits when it comes to particularly early invasive and melanoma in situ of the nail. We've been able to use this, and it's termed functional surgery because we're not automatically having to amputate. We're allowing people to go home with wounds on their fingers, but still have the digit intact. So, and one other thing that I'll say about, Mohs surgery in general is that when you have a wide local excision done compared to Mohs surgery, we already know that we're looking at 100% of the cells underneath the microscope for Mohs. If one were to venture a guess at the amount of the margin or the edges that one evaluates through a standard wide local excision, most people are quite alarmed. And they should be, because that number is less than 0.1%. So when you think about, well, the kind of consideration for the application of Mohs in the realm of melanoma, there's so much tissue left unseen that even with adequate margins, we simply don't know what we don't know because we haven't evaluated all of the tissue. I think that this is something that's starting to become more of a, I don't want to say standard yet because it's a very controversial topic, but the evidence is there, and oftentimes guidelines lag behind evidence. And so this really requires, if any of you have or are afflicted by melanoma or know someone that has a melanoma, really ask these questions to your surgeon, to your dermatologist, get information, be your own best advocate, and I think that will get you the answers for really the best approach for you. I'll pause there. I don't see any additional questions so far, and I think we've kind of fleshed out a lot of what to expect from skin surgery. I welcome any additional questions, but I really appreciate this time, and for everybody weighing in. I think this is you've had some excellent questions, and I really hope that more people are better informed. And I encourage you, if you need more information about the technique, again, the mohscollege.org is a great place to start. So I wanted to take this opportunity to thank Skin Cancer Education and Research Foundation, and I wish you all a very happy holiday.